free paper session number 2 for oculoplasty and orbit this morning. And this is a competitive section, so we expect the presenters to follow time, because you know the timekeeping is very important in any competitive section, and exceeding time variably will get you negative marks or even disqualify, depending on the strictness of the timekeeping rules of the meeting. The second thing is, obviously there are going to be marks allotted on the basis of your work done, the content, the presentation, and time. So all of you know that when you are presenting here. Those who are not ratified members of the AIOS will be allowed to present. Obviously, presentation is a privilege, and we can interact and ask questions, and there can be healthy discussion, but they will be not eligible for either the marks or the later awards on the basis of these marks. So we are 4 of us, and there's one person who's not yet come, Dr. Rolika Bansal. She's not here, and could somebody call her up and find out whether she's coming? So in case she's coming, we can wait for a minute or two, but otherwise we are going to be starting. Yeah. So okay, let's start with the first presenter, who's Dr. Surya Narasimhan. Not there? Okay, the second one is presenting author is Dr. Bharati Sundaravardhanan. No? All right. Then third is Dr. Kirti Reddy Vontela. No? Now I do not know whether people who have missed their turn and are not in the hall on time should be allowed to present. We'll, or if they come in little later, I think we'll be gracious enough to let them present. After all, you don't get opportunities every day to present at a meeting like the AIOS. Shefali. The next is Dr. Shefali Chahar. Okay. No, there are 2. 3. There are others. Let's go orderly fashion. Dr. Shefali Chahar is not there. Then we have Dr. Ajit Kumar. Yes. Let's have Dr. Ajit Kumar is a ratified member, and so will be eligible to get marks. And this talk is on conjunctival reconstruction in contracted socket, a case series. What is the amount of time allotted? Sorry? Okay. Yeah. So presentation is 5 minutes. टाइमर 5 पे करेंगे? 5 कर दीजिए. और at the end of the session we mark the absentees. I think if there's consensus on that. टाइमर 5 पे करने के बाद हाँ अभी स्टॉप करके रीसेट कर दीजिए. इसमें बहुत गड़बड़ हो जाता है कई बार. 5 पे एकदम स्ट्रिक्टली 5.
Good morning, and first of all, welcome to all of you for the first AIOC midterm. There is no nil financial interest, and we are in a contracted socket defines absence of functional eyeball from orbit. And what happens after a patient expectations about aesthetics after anophthalmia, what they understand, it's ideal ocular prosthesis is a natural looking that friends and family don't know, but the medical point of view is eyelids should be at a normal position, ability to blink, and eyelashes in normal position, symmetrical with healthy eye, and also as good motility custom processes. So a common scenario is whenever a patient comes to us, we give a radius stock artificial prosthesis in presence of adequate socket, which is called grade 0 socket, where we have a adequate 13 millimeter of superior fornix depth, 9 millimeter of proxy around the lower fornix, and grade 0 socket is also lined with a healthy conjunctiva, has deep and well formed cervices. So, but for Krisa et al. Has a 5 grades of management of contracted socket. Grade 1 is shallow lower fornix with a shelving of the lower fornix, while grade 2 is the loss of upper as well as lower fornices, and grade 3 is the loss of upper, lower, medial and lateral fornices, while grade 4 has a palpebral aperture narrowing as well in a horizontal and vertical dimensions, while the 5 is the repeated results after repeated reconstruction. So, aim of construction is to establish stable furnaces by increasing the surface area or by increasing the size, and the ocular processes should be light once provided latter to take its supports from infraorbital rim, not the leads. So, the options are, if it is minimal defects, we can go with the Z-plasty and local conjunctival flap. Moderate contracture, it can be buccal mucosal graft, and volume loss, definitely dermis fat graft is required, and if there is severe contracture, we can go with the prosthesis, which is itself designed to be fit there. So, prevention is with the use of conformer in the early childhood to allow the growth of the orbit, and if it is in a posterior period, it also helps to help the oculars increase the size of the conducted socket. My first case was a one-eyed 67 years old sannyasi presented with inability to use old prosthesis as it slips every time from socket and has lost many in due course way back in 2010. So, you can see post surgery it was conjunctival socket reconstruction was done using buccal mucosal graft in 2010, and he got a custom made prosthesis after alligate at different places after socket reconstruction. This is the second case when we can say it looks like a grade 4 socket, and the buccal mucosal graft was again taken. Conformer were used in an increasing size, and later on this socket become large enough to allow the radius stock custom prosthesis itself. So, while we are doing the buccal mucosal graft, the graft is taken from the buccal mucosa for this grade 3 contracted socket with symblepharon, and later on this fornix deepening sutures were also given to take the support from the intraorbital loop to make it more deeper. And this lady has an exposed hydroxyapatite orbital implant, and she has undergone dermis fat graft but it was rejected because she had copious discharge during the due to that, and but she was unable to go the re-DFG. We were able to force the explant from the socket, and later all the customized prosthesis was provided. So, many a time you work, but there is a unsatisfied patients in a young 22-year-old girl which come for the prosthesis, but once made she was not satisfied with because of the higher expectation. You see the results here in this area. So, it is very important to promise less and deliver more in such cases, and also have the girl teenagers are very difficult to get satisfied than the boy teenagers, and but at the same time you may get the satisfied patients where the after a prosthesis when it is made to us, it can be a better scleral show in this case, but still it's acceptable to the patient. So this patient, where we always say this patient has come to us for the orbital implant in tooth.
You just finish this slide.
Okay. Has come in 2017 for the orbital implant, and we have counseled to accept the prosthetic contact lens for 3 years over his physical eye, and it was cosmetically acceptable at that time. Later on, we have provided customized prosthetic cell for the over the prosthetic eyeball, and we are planning, because it's quite natural looking at this moment. We have a plan, once it become more physical, we can have explant it and then provide the another orbital implant. So, to conclude, can I conclude, sir?
Yeah, just conclude. Yeah.
Yes. So, Take-home messages contracted socket needs a special and meticulous attention. It raises the morale of the person. Correct assessment and meticulous step planning with informed patient is key to success, and custom-made processes adds acceptability and better cost message. Our publication is there on
Yeah.
that.
Thank you, Dr. Ajit. I think that was a nice presentation of different kinds of grafts used. In the patient who had the failed DFG, dermis fat graft, what was actually done? I couldn't.
So the graft was taken from the glute area.
No, the failed DFG. So
Yes.
the patient came to you with the failure of DFG. Was a repeat DFG done for the patient, or?
So we have offered them the repeat DFG, but patient has rejected that. I want to get rid of this hydroxyplane because he was suffering since last 7 years. So at this she was in a distress.
Right.
She was not even. We have given 2 to 3 times to think over on that one.
Yes.
But she says that just take it out.
So you removed the graft,
So
but how did you cover that area?
No, I have removed the implant basically,
Yeah.
and that socket was good. Basically, the the conjunctival furnaces are good.
Okay.
So we have provided the prosthesis, which has a high toricity, you can say, and to have a good acceptance.
Sure, sure. So you did not do another volume replacement, or you did not need any surface area expansion?
Definitely not required,
Not
especially.
required. Fine, fine. Okay. Right. Any other questions, Dr. Pammi?
As a oculoplasty person, and the day is just 6 on, I presented on contacted socket. So that's good that you manage the patient, but what I found is that when you analyze the evolution of the contacted socket, there's a two thing that is there: the surface and the volume.
Yes.
You can't correct just surface and give it prosthesis. You have to correct the volume simultaneously. And the first thing is like contacted socket is not the absence of eyeball. It is like an ophthalmos. If eyeball is not there, it's an ophthalmos. It could be the clinical ophthalmos. So contacted socket is something like when you have this like eyeball can be just a small micro-ophthalmos along with still the contacted fornices.
So it's an absence of functional eyeball.
Yeah, so that is an ophthalmic socket.
Yes.
So what I like, you have done the bill as a the surface part, but the simultaneously like sir asked that in that case, especially I want to answer, if DFS is fail, so there was one patient that I presented that day, it was a grade 4 contracture and the patient doesn't have the surface, doesn't have the volume. So there was two option of going that. You can first correct the DFG. DFG will give you the volume also and the surface, followed by the MMG to
Yes.
create more surface. But that patient actually wanted less morbidity because DFG and MMG is like taking the graft from the two area. One is oral mucosa and one is gluteal. So what I did is there's like, I put implant for the volume connection. Done it's a very small eye, severe thiatrical eye. I done enucleation. I put implant. First I corrected the volume, and then for the surface connection I put on. I did AMG.
Yes.
And so, just my message is that evaluate both part and do correction for the both part. So then your patient will be happy. Like the young girl you have shown. So even see, if you will assess the volume, the superior sulcus deformity, that actually give the idea how much the volume is there.
Yes. Yes.
So if you will evaluate well and do this step by steps, this all socket patient can be make happy.
Yes.
So my message is just go like step by step and do. Otherwise the surface part is done well.
Definitely.
Yeah, thank you.
So we have some certain experience. In few cases I was unable to show.
Sure.
That's where we think of that we can that patient will require a surgery, but only the customized prosthesis, the cell, has given such a result that the prosthesis rotation has gone out and the toricity has little so was better. So
Absolutely. There is absolutely a huge area, and you touched upon some of the
That's-
areas
yes.
in a very nice way. Thank you, Dr. Ajit.
thank you so much.
Now we come to the next presenter. Is Dr. Neha Shri here? We'd like to check about the others. Is Dr. Pradyumna Mishra not here? And the last speaker of this session was supposed to be Nishi Prasad. You are here. Okay, right. Shifa, you just come in, so we'll call you in order. Please sit. No. Sorry? We'll call you. Yeah. My contact.
Yeah. A very good morning to all of you. I will be presenting partial orbital anatomy for refractive
Timer on.
epiphora, a way to go.
Yeah.
Epiphora can range from mild to severe. In milder form, it can cause irritation, burning sensation, blurring of vision, but in severe cases, it can cause unpleasant swelling, skin maceration, constant burning, sometimes causes ectropia and lot of problems. It can be due to the epiphora, can be due to the obstructive causes, and can be due to the functional causes. Literature shows that total number of functional epiphora exceeds the number of epiphora due to the obstruction alone. So, in the cases of simple cases like NLDO, we have the option of DCR with very good success rate. But in the cases like traumatic NLDO, proximal cannular obstruction, punctal agenesis, traumatic unsalvageable lacrimal system, we have limited options. One option is to go ahead with the conjunctival DCR. It's a scarlet surgery, good success rate in expert hand, but variable success rate in not the experienced hand, and chances of extrusion of Jones tube is a known complication. It's a time-consuming surgery, needs hospital admission. Other option we have is the lacrimal gland Botox injection. It's a OPD-based procedure. It's a less invasive surgery, but needs repeat injection, and it's not cost-effective for the patient. Other option which I will be discussing is the partial orbital decryodonectomy. It's a less time-consuming surgery, less invasive daycare procedure, but again, it is not suitable for the dry eye patients, should be avoided in children, and long-term success is still unknown. So, objective of my study is efficacy and safety of orbital partial decryodonectomy in patient with the persistent epiphora. It's a prospective interventional pilot study. We included the patient of punctal agenesis, cannular obstruction, unsalvageable proximal system post-trauma, post-DCT rehabilitation, multiple times failed DCR, and Monk score more than 2. We excluded the patient with the simple NLDO and patient with the dry eye, children's, patient unwilling to go under surgery, and Monk score 2 or less than 2. So in the preoperative assessment, we did the Monk score for the patient, and after that we did the normal slit lamp evaluation was done. Summers test was done to rule out the dry eye, and ASOCT was done to measure the tear film height, and NCCT orbit is must before surgery to check for the presence of lacrimal gland, because we have seen the patient with the complete lacrimal gland absence, and there is no gland even on the histopath also. So the NCCT orbit is must. Primary study outcome was interpreted as successful outcome at least 2-point improvement in Monk score, qualified success at least 1-point improvement in Monk score with significant improvement reported by the patient. Failure was described as no improvement in Monk score as well as no improvement reported by the patient. I'll just briefly show the this thing. Lateral licorice incision was given, orbicularis was dissected, and septum was opened up. After removing the septum, we see the lacrimal gland, and the lacrimal gland should be differentiated by the orbital fat. Almost 50 to 60% of the gland was removed. Fat was placed back, and incision was closed. And we had 6 eyes of 6 patients, 3 were male and 3 were female, and 1 patient has congenital punctal agenesis, and 5 has the proximal cannular obstruction. Average age was 49.3 years, and median follow-up was 7 months. Outcome was Monk score reduced from 4 to 1.8 in the post-op period. Average reduction was 60%. Summers score though reduced from 31.5 to 25, but this was not significant to cause the dry eye. TBUT was very minor changes in TBUT was noted. We can see that pre-op TFS in the very nicely TFS raised tear film height in the pre-op and post-op. This is the post-op of the same patient, so in reduced tear film height. This is the graph of the patient's individual patient. So average TFS reduced from 2.5 to 0.3 mm. In the ASOCT also we can see a raised tear film height and reduced tear film height, and average reduced from 1697 micron to 490 micron. None of the patient have developed complication. And our limitations is a pilot study, quantitative analysis of lacrimal gland excision and its correlation with the reduction of Monk score TFS was not done, which we are planning to do now. Sample size is less, so we need a multi-center study. Follow-up duration should be more. So to conclude, partial orbital dacryodenectomy could be an effective and safe procedure for patients with a defective EP4R. These are my differences. Thank you.
Time? Is okay, well within time? Okay, right.
Thank you, sir.
Good. I think that's a nice presentation.
Thank
But I mean, which are the two parts of the lacrimal gland?
It's the orbital part and the palpebral part.
So this was a lid crease incision.
Yeah, by the lid crease incision, we reach the orbital rim, and when we open the septum, we reach directly on the orbital part of the, because the palpebral part is on the LPS, aponeurosis. We don't touch that palpebral part because the excretory glands, the secreting glands passes through the palpebral part.
Right.
And removing the palpebral part, literature has, earlier it was done that they used to remove the palpebral part, and it used to cause a lot of conjunctivitis sicca in those patients because due to removal all the ducts. So we don't touch the ducts, we just remove 50 to 60% of the orbital part of the lacrimal gland.
Right. So to avoid damage to the ductules,
Yes.
all of which are draining through that.
Yeah.
But that will help, right?
So if you remove all the ducts, though lacrimal systems are capable of secreting, they secrete 95% of the secretion is due to lacrimal gland. But if you remove all the ducts, those secretion will also not be completely distributed on the surface.
In practical terms, it doesn't happen, but I think the logic is fair enough that
Yeah,
you're only
and
reducing.
because we have lot of literature in 1980s, they used to do the palpebral dacryodenectomy, but that was failed, not used now because of the dryness and lot of conjunctivitis sicca in those patients.
What was the follow-up duration you have seen?
7 months the median follow-up duration.
Okay.
Till now, it's a pilot study. Till now, we are following those patients now also, but till now the median follow-up is 7 months.
During follow-up, you have seen that tear meniscus height is increasing.
No, till now we have not seen that tear meniscus height is increasing. Though the
How frequently you are following? Means first post-op? second-
first post-op day is just first post-op day, then first 1 week, then 1 month, then 3 months, and then 6 months.
Tear meniscus height is maintained.
Yeah, that
It's
is
not
maintained.
increasing.
No, ma'am.
Means in future it will.
Yeah, we are following those patients because we need more follow-up duration, of course. This is a newer interventional study, so we need more follow-up duration before coming to a conclusion.
But on table, how will you decide is 50% or 60%?
That is the limitation of our study, that now the volumetric analysis we are not doing now, but we are planning to do in future the volumetric analysis by the CT scan also, post-op CT scan also, and on table also we are trying to do that we measure the volume of the lacrimal gland which we are taking out.
Try to correlate that.
Yeah, try to correlate with the
Yes, your
CT scan
study
and
needs-
intra-op.
A study needs more follow-up or more.
Yeah, ma'am, it's a new study, new interventional study,
New
so more follow-up is required, of course.
And any such study, the subjective part is very, very important.
Yeah, we have taken the quality of life assessment also,
Yeah.
but we are just we are waiting for the final, like 1 year and 1.5 year, we can take that there's no reoccurrence of the tearing and all that, then we'll take the final also quality of life. But now also at every visit, 3 months and 1 month, we have taken the qualitative analysis,
So you
quality
have-
of life assessment.
So you have a pro forma for that? the
Yeah, we
testing?
have GBI score is the known performer for the quality of life assessment. So we are taking following the GBI score.
Yeah. No, for the watering itself,
Yes.
patient's subjective sensation of watering.
Yeah, that is
Like
the monk score we are
Score
taking.
you're taking.
Yeah.
Okay, so that's the main subjective part.
Ye-
and
yes.
then you're measuring.
Yes.
Okay. So that's a nice study, and I think.
Thank you, sir.
Thank you
Good
for
presentation.
the
Thank you,
nice
sir.
presentation.
Thank you, Neha. May I call the next speaker, Dr. Pradyum Mishra. He will be going to present John's procedure in the management of involutional entropion, the roller coaster.
ऐसे मतलब साइड पे जाएंगे ये वाला है ना Good morning to all. Today my presentation is on Jones procedure in the management of involutional entropy on the roller coaster. Financial support and sponsorship none, conflict of interest none. In 1960, Lester Jones reported the following changes in a senile eye. The tonicity of the skin and the superficial fascia is lost and they become redundant and less adherent to the underlying preceptal muscle. Senile entropion causes enophthalmos and the pressure of the globe against the tarsi is decreased. Because of enophthalmos and normal atony as a result of aging process, the deep facial layers linked to the base of the tarsus become relaxed. This decreases the pressure on the lower border of the tarsus and increasing pressure in the upper border, thus causing the tarsus to turn inward at 90 degrees. During contraction, the lower preceptal muscle rises above the lower pretarsus muscle. This decreases the pressure at the root of the tarsus and loosens its hold on the basal orbital septum. The contributing etiological factors for involutional entropion are the overriding of the preceptal orbicularis over the pretarsus orbicularis, horizontal laxity of the lid, which is due to the laxity of the medial and lateral canthal tendons, and vertical lid instability is due to disinsertion or dehiscence of the lower lid retractors. Tests to detect the horizontal lid laxity are the positive distraction test and the snapback test. Other pathological findings in involutional entropion are the lateral and the medial canthal tendon laxity, lower retractor laxity, dry eye syndrome, chronic blepharitis and chronic conjunctivitis, corneal abrasions, ulcerations, microbial keratitis, and significant visual loss if it is untreated. What is the principle of Jones procedure? The capsulopalpebral fascia is tightened by the placating the lower eyelid retractors, thus reinforcing the vertical traction power of the lower lid ligaments. Everting sutures pull their transfer their pull to the anterior surface of the tarsal plate, thus placating the attenuated lower lid retractors. They also prevent the upward migration of the preceptal orbicularis by creating a horizontal barrier. Objective is to study the safety and efficacy of Jones procedure in the management of involutional entropion. Materials and methods, study place Department of Ophthalmology at a tertiary care center, Western Odisha. Study period January 2021 to August 2022. Study design, it is a prospective observational study. Inclusion criteria, all cases of involutional entropion. Exclusion criteria, spastic, cicatricial and congenital entropion, and those with previous eyelid surgeries. The surgical procedure, after giving a horizontal skin incision 4 mm below the eyelash line with a diathermy blade, the orbicularis oculi muscle was exposed. After ensuring appropriate homeostasis, the skin flap was elevated and the pre-aponeurotic fat retracted to expose the lower lid retractors. With the help of 5-0 Mercier suture, the lower orbicularis oculi in inferior eyelid retractor and the top portion of the skin incision were stitched together. This becomes the cardinal suture. Two more similar cardinal sutures were placed similar to the central one. These sutures were adjusted to prevent any under or overcorrection. Similar to the cardinal sutures, two more sutures were placed, one medially and one laterally. Patients were evaluated 48 hours post-operative, followed by 2 weeks, 4 weeks and 6 months later. The height of the palpebral fissure and the symmetry between the contralateral and the corrected eyelid was examined. So these are the results. In our study, we had 8 males and 11 females. So there was no significant gender predominance in cases of involutional entropion. In our study, the unilateral entropion was more as compared to the bilateral entropion. After one eye showed infection in the post-operative period due to poor cleanliness, which was treated with antibiotics. One eye showed recurrence, 2 eyes were undercorrected, while the rest 22 eyes were corrected successfully. So this is the before and after image. Involution entropion is one of the commonest type of palpebral malposition. Medical therapy like Botox provides only short-term relief, thus making medical management as the surgical management as single most effective therapy. Lester Jones described the Jones procedure in which he identified the lower eyelid retractors and reattached them to the tarsus. The long-term success of the procedure is contingent upon generation of a fibrotic scar along suture tracks. Safe et al. Found a strong fibrotic and inflammatory reaction in the lower lid tissues 2 weeks post-op. In our study, no significant age and gender differences found. Unilateral cases were more as compared to that of bilateral. Success rate is 88% in accordance with the study done by Costas Bobrodis et al. Jones procedure is safe, effective and cost efficient option for involutional entropion involving the lower eyelid. Our study indicates that after the procedure there is a low risk of reference, minor skin incision is required, short surgical time, quick surgical skill acquisition, no intra-op complications, and it is aesthetically acceptable to the patient. Thank you.
What was the longest duration of follow-up?
So 6 months.
6 months. So in these 6 months, did you have any patients who had recurrence?
Only one patient
Out of?
out of, sir, we had, sir, 19 patients of 25 eyes of 19 patients, sir.
25 eyes, 19
Patients.
patients, one recurrence.
One recurrence,
eye.
sir.
Okay. Did you have any overcorrection
No, sir, no overcorrection, sir.
which needed massage?
So
and
no
other
overcorrection
things?
or no undercorrection, only.
Who were the surgeons? What was the skill level or the training level of the surgeons?
Sir, it was mainly done by our associate professor, Dr. Sir Mishra Behra.
Okay, so basically a consultant who
Yes.
had done the operation. So I think Jones procedure is a very well established procedure, but obviously it does not correct some of the factors. At least one of the important factors it does not correct is the lower lid laxity to
Yes,
that
sir.
extent. So today many of us are not using Jones procedure so much. So, but I'm happy that you've done a good study and you've
Thank you, sir.
analyzed it.
I just want to, as the sir said that, so like the recurrence in the patient happened. So all the patient, have you analyzed how much they have the lateral lid laxity?
Sir, ma'am?
How much they have the lateral lid laxity? So if you have like just done the Jones procedure, like, so then you are just taking care part of the lamella.
Yes.
And if you're not taking care part of the canthus, that is basically the pillars.
Yes, ma'am.
Yeah. So the recurrence can happen over the period. So what like sir said, because the Jones, sometimes the recurrence happens, but if you are doing this, if there is a lateral laxity also, and if you are just doing the lateral tarsal ST plus Jones, these patients have a better outcome in a long term. The recurrence rate is low also because you have taken care of this canthi. So Jones plus LTS is actually gives better outcome,
Yes.
what we usually practice. But for that you have to see that is there a lateral lid laxity or there or not.
What was done
Yeah.
for that recurrence patient who had a recurrence? Which procedure was done?
Yeah,
No.
that's a good question. What surgery was done?
Uh,
Oh.
Ma'am, we have not yet planned. Actually, we asked the patient to stay, then she denied any further surgery.
Okay. All right. Thank you.
Thank you.
The next person in order is Dr. Nishi Prasad. Yeah.
Ocular manifestations in rhinoorbital cerebral mucormycosis post-COVID-19. So COVID-19 pandemic has affected millions of life all over the world. It has led to complications, secondary complications like bacterial and fungal. Mucormycosis is one of these complications. ROCM is an acute fatal fungal infection caused by Zygomycetes family. It's an aggressive opportunistic infection found mostly in immunocompromised individuals. Aim is to study spectrum of ocular manifestations and their visual outcome in mucormycosis patient post-COVID-19. So this was a hospital-based retrospective observational study done in Gandhi Medical College, Bhopal for a period of 6 months. Initial 100 diagnosed cases of COVID-19 related ROCM was taken. Diagnosis was based on histopathological and KH mount from nasal cavity, and data were compiled and statistically analyzed. So total 100 patients were taken, minimum age of the patient 18, maximum 80, mean being 50.7 years, male 71% and female 29%. So according to presenting features, so maximum patient presented with proptosis and conjunctival chemosis, followed by loss of vision, periorbital edema, ptosis, orbital pain, extraocular muscle limitation, deviation of eye and diminution of vision. And according to visual acuity, so 54 patients presented with no perception of light, 10 patients with only perception of light, 14 patients up to counting finger, 10 patients from counting finger to 624, and 12 patients from 618 to 66 vision. So according to imaging features, so 72 patients had orbital cellulitis, 52 patients had orbital apex involvement, 24 patients with cavernous sinus involvement, 30 patients with CNS involvement, and all 100 patients with sinus involvement. So cases according to systemic status, so known patients, known diabetic before contracting COVID was in 62 patients, 38 patients had developed de novo diabetes while on COVID treatment, 88 patients had uncontrolled diabetes, 34 patient was on other immunosuppressive state, and mean HbA1c was 11.5. So management of mucormycosis, 96 patient was given IV liposomal amphotericin B followed by oral posaconazole, 90 patient had sinus debridement, 50 patient had transcutaneous retrobulbar amphotericin B, 36 patient had undergone orbital exentration, and 12 patients debridement of orbital necrotic tissue with orbital irrigation with amphotericin B. So unfavorable outcome was seen in 78%, favorable outcome in 22%, and mortality in 9 patients. So clinical outcome, so unfavorable outcome was seen in patients with cavernous sinus involvement, orbital apex syndrome, uncontrolled diabetes, and CNS involvement. And factors predicting mortality was observed to be only CNS involvement. These are some photographs. This is a lady with third nerve palsy with bilateral pansinusitis and left cavernous sinus thrombosis. This is a neurotropic keratitis with no orbital or cranial extension. Orbital apex syndrome, left eye showing CRAO picture, and MRI brain showing left ICA thrombosis. Bilateral presentation with involving both intra and extraconal spaces with extensive bilateral pansinusitis. Orbital spread is through nasolacrimal duct, orbital apex, lamina praepatia, central retinal artery, pterygopalatine fossa. So ROCM is a known occurrence in COVID-19 affected patients. The orbital involvement is due to arterial thrombosis affecting the wall of the orbit, oculomotor and optic nerves responsible for blindness with or without thrombosis of the ophthalmic artery. It is initially unilateral and can gradually progress to other eye. It is marked by orbital pain, diplopia, ophthalmoplegia, periorbital edema, chemosis, exophthalmia, or even blindness. So in this study, uncontrolled diabetes, involvement of orbital apex, cavernous sinus, and CNS determined an unfavorable outcome, and CNS involvement was the only factor determining mortality of the patient. Conclusion, ROCM is an acute fatal opportunistic fungal infection affecting mainly diabetic or immunocompromised individuals. Timely diagnosis and intervention in the form of surgical debridement and antifungal therapy are critical aspects in improving clinical outcomes in such patients. Hence, it is prudent to take multidisciplinary approach by physicians, ophthalmologists, neurologists, and ENT surgeons for successful eradication of infection and survival of the patient. These are my references. Thank you.
Yeah, thank you. That was a wonderful presentation. I think and a lot of good work has been done. Just a couple of questions that I have, and I'm sure the panelists would also want some questions. The first thing is, of the patients who underwent exentration, how many died?
Sir,
in other words, was exentration a life-saving procedure?
No, sir. 3 patients died even after exentration, especially in those with bilateral presentation.
Right. The second question I have is that, you know, that before this epidemic that we saw in India and in some parts of the world, TRAMB was still not an established treatment modality. But circumstances of the pandemic forced all the ophthalmologists to embrace TRAMB as a treatment procedure. So in your series of patients, very large number of patients received TRAMB. So what was the average number of injections they needed, and did any of them go on to exentration? I mean, if you have the data, I mean, because this is interesting and very nice series which you have worked up. So
we used to give TRAMB for alternate day, maximum 5 for a patient, and even after that, maximum patient showed favorable outcome after TRAMB, but some patients even progressed
and
required orbital exentration.
Right. So I think, yeah. Any other questions?
like, have you managed this patient with the ENT colleagues?
Yes, ma'am.
Yeah.
ENT
So, like,
and
first
physicians.
they have taken care of the sinus. Yes.
Yes, sinus debridement was done by ENT surgeons, ma'am.
Yeah. So that is
Yes.
very important to patient because it seems like it's done by, because if you don't have the ENT colleague supports, this is the one thing where you, after this pandemic, you it's like come more closer in managing
Yes,
this patient.
I know, ma'am.
And another
ENT
question is like the sir said that the after the tram injection, so the exentation, how much time like they take to, like, after how many injection the sir mentioned that they take, after that you say कि okay there is a no response and patient Surya, you managed clinically on the basis of MRI.
Ma'am,
How do you took that judgment?
yes, average we had given from 3 to 5 sittings, and even after 5 sittings, if the patient started progressing, we still waited for 1 to 2 weeks, but still progression, and on even on repeat MRI, patient was worsening, then we had planned, and no vision was left, then we had planned for orbital exenteration, ma'am.
Okay. And another,
With consent of from ENT and physicians.
and because you have a very good number data, so
Yes,
you
ma'am.
like can do the some type of regression analysis to see that which factor is associated with unfavorable outcome, like just so that
Yes,
will
ma'am.
give you more value, ki how much is like this much is the more risk or this ratio.
Yes, ma'am.
So,
4 factors were there for unfavorable
yeah,
outcome.
so I will say just do with the regression model.
Regression model. Okay, ma'am. Thank you.
Nice, thank you. So the next speaker is Dr. Prabjot Singh here. All right. In the meantime, we just check if Dr. Shaleen Shah is not here. Then any of the speakers who missed their turn? Sorry? Yeah, Shefali, yeah. So after this, Dr. Shefali goes in.
Good morning. Good morning. I will be presenting a paper on Delman-Orthai syndrome, a case report of an atypical variant. Delman-Orthai syndrome is characterized by microophthalmia or anophthalmia, orbital cysts, periocular cystic appendages, skin tags, focal dermal lesions, or cerebral abnormalities. Here I am presenting a case of 4-year-old male who presented to us with epibulbar dermoids, upper lid colobomas, and on evaluation was found to have Delman syndrome. In literature, only 43 cases have been reported so far. So it was the 44th case which reported to us worldwide, and it was one of the atypical variants, which is the first time we were getting it. So the parents brought a child to us with complaint of fleshy red mass of the white part of eye in both the eyes, with abnormally shaped eyelids since birth, delayed developmental milestones, and a patch of hair loss on one side. There was no history of orbital mass or seizures. On examination under anesthesia, we found that there were epibulbar dermoids in both the eyes. There were upper eyelid colobomas. There was microcornea in both the eyes, more so in the left, and there was more than 270-degree limbal stem cell deficiency in both the eyes. On systemic examination, we found there were nodular skin tags on both the eyes. However, there were no tags on the skin as such, which are found in typical syndromes. There was bluish-white pigmentation over the back and other areas of the body. There was large frontal bone and deformed temporoparietal bones. Also, there was temporoparietal alopecia on one side. And on CNS examination, we found a positive Babinski sign. Based on ocular and systemic findings, he was diagnosed to have atypical variant of Delman-Orthai syndrome. We did a MRI which showed generalized cerebral atrophy and enlarged ventricular system with prominent Verco-Robin spaces. Interestingly, the cerebral cyst, corpus callosum agenesis, hindbrain abnormalities which are typically associated with this syndrome were absent in this case, as was the presence of orbital cyst, indicating that this might be possibly be an incomplete variant of the syndrome. As a management, in this case, we only prescribed spectacles. After performing refraction and anesthesia, he was also referred for pediatric and neurosurgical consultation to enable opportune management. This paper highlights a very well clinical presentation of Delman syndrome. The child in our case lacked the typical features of Delman or Thies syndrome, based upon which we could have missed the case. The clinical features of Delman syndrome can overlap with other syndrome, which constitutes a diagnostic dilemma. These conditions include golden hour, Goltz-Gorling, and other syndromes, including the Aicardi syndrome. As a conclusion, Delman-Orthai syndrome is characterized by a triad of involvement of eyes, skin, brain, and hence also called ocular cerebrocutaneous syndrome. Individuals with this condition might experience seizures, intellectual disability, and psychomotor retardation. The management is multidisciplinary and could be symptomatic or supportive. The medical management is in the form of anti-seizure medications. Thank you.
Right. That is a very nicely worked up, very rare condition. So I would like to ask, because many of these are like ectodermal, or many of these have very complex etiology. And today, how did you come to this diagnosis? Was it a random way of putting 2 and 2 together, or did you use any of the search engines which are available?
The most of
today?
the symptoms related to the Delman-Orthai syndrome, we also sent for genome testing. We found no mutation. Since it is a somatic mosaic mutation, we did not find any mutation. Then we ruled out the other syndromes. There were no associated ear abnormalities to rule out the Goltz-Gorlin syndrome. There was no polydactyly syndactyly. There was, it was a male child, so we ruled out the Aicardi syndrome. So we ruled out all the other syndromes, and it was the best fitting into the Delman-Orthai syndrome. And it was first of the atypical variants which was reported so far in the
literature.
literature.
It's been very well worked up. My only question was that there are today pediatric geneticists and syndromic specialists, and there is software which is constantly updated. For example, your case gets published, then that will also be updated, so that it helps people to make a diagnosis and prognosticate.
We have
and
already published this case in Maharashtra Journal of Ophthalmology.
Okay, that's very nice. So, why the eyelid colobomas did not need any management?
Sir, it was a very small eyelid coloboma and was not a problem in the vision, and if it could have been a large coloboma, we could have freshened up the areas and reanastomosed the areas.
Sure. Thank you.
Very nice presentation. Only one query. The parents has come for your to you for the red mass.
Yes.
But you have done only refraction. So only given
The
spectacles.
epibulbar dermoids were not extending up to the visual axis, not over the cornea, and they were very
but
small.
It will cause repeated change in the refraction also, na?
No, they were not extending at all. We have followed the case for almost around 2 years, ma'am. The patient came to us around in 2018, and since 2021, the mass was limited to that area only. Okay. So, since the patient has sclerocornea, microophthalmos, we did not want to take any intervention. Yes. Also, the patient did not have any orbital cyst, so it was not worthy of any intervention.
How much vision it has?
The patient has a 5/60 in right eye with BCVA and 6/60 in left eye.
Thank you.
What was the extraocular motility of that patient?
The motility was very normal, full and free.
Extensive.
Motility
So it
was
was
full
not
and free.
happening
The
to
limbal dermoids were not limiting the motility, ma'am.
So I think what as said, like maybe you are not able to, but then as a child grows, might need the correction for dermoid and also.
Yeah, we are following up the case, ma'am.
Sure.
It was shown to all these specialties. Yeah.
Thank you very much.
Thank you.
Now we call upon Dr. Shefali Chahar. Has any other presenter who could not come on time reported? No. Okay.
A very good morning, everyone. To the respected judges, at the outset, I would like to thank AIOS for this wonderful opportunity and my mentors for their constant inspiration and guidance. My topic is transconjunctival intra-elevator triamcinolone for upper lid retraction in thyroid eye disease. So thyroid eye disease, as we all know, it's an enigma. The most common disease affecting the orbit. It is complex, and it is a poorly understood autoimmune pathology. What is happening here is thyroid-stimulating antibodies are activating the fibroblasts, leading to all the changes that we see in the presentation, which are lid retraction, myopathy, proptosis, or optic nerve dysfunction. Also, thyroid has a very natural course of the disease, which is commonly called as a Rundle's curve, showing a dynamic phase, which is active, a plateau phase, and a phase of static phase. So the most common eyelid symptoms that we see is eyelid retraction, which is seen in 90% of the cases of thyroid eye disease. The mechanism involved, the hypothesis proposed, are overaction of the levator and the molars, that is the increased sympathetic tone, the fixation duress, levator hypertrophy, levator muscle contraction or fibrosis, abnormal adhesion between levator and surrounding structures, scarring and or inflammation of the septum and the anterior lamellae. So what are the challenges we are facing here? The functional challenges include the lag of thalamus and exposure keratopathy, and the cosmetic challenges which can have a psychosocial impact on the patients. The management options in our hand is surgical or non-surgical. Well, for any option that we have few questions. What to use, when to use, how to use, what are the results, can we use it in active phase or the inactive phase, or how many injections will be required here? Surgical options, we know it can only be taken up in the inactive stage, fibrosis when has set in. It is unpredictable, irreversible, invasive. It can lead to under or over correction and inadequate lid contour. So non-surgical options are feasible here, like botulinum toxin, hyaluronic acid gel fillers, or triamcinolone injection. So in our study, we evaluated the role of transconjunctival intralevator injection in upper eyelid retraction in thyroid eye disease. It was a retrospective interventional case series in which 37 eyes of 22 patients were studied between 2019 to 2022. And in the OPD setting, 1 to 2 ml of triamcinolone injection was given subconjunctivally in cases of lid retraction. Mean age that we had was 46.2 years with 9 males and 13 females in different states of disease like hyperuthyroids. It was used actually in our case series in both active and inactive disease, and almost the equal number, 12 and 10. So the mean number of injections that we could give was 1.7 in the range of 1 to 4. The mean average dose was 23.7 milligram, and time to maximal response was 37 weeks. And at every stage, we measure the MRD1, the palpebral fissure height, the superior scleral show, and the lag of thalamus in all these patients. And as you can see, the pre and the post treatment, there was a significant change, statistically significant change in all the patients here. The mean follow-up of 16.3, MRD1 was 4.5 with a range of 2 to 10 and showing improvement in all our cases. Mean reduction in MRD1 was 1.5 millimeters and no significant regression was seen from the maximal response. Only one patient showed increased intraocular pressure, which was managed by topical anti-glaucoma medicines. After one visit, it was under control. So all the questions that we set out to question before the study, like what, when, how many results, we could answer with this study, being that it could be used very well in both active stage of the disease, inactive stage of the disease. 1 to 4 injections, subconjunctival given, provided very good results with no local side effects, no ocular side effects. Long-term effect was seen in all our cases, and it provided beautiful results for both functional and cosmetic things. Earlier, only a handful of doctors have actually published regarding the use of triamcinolone acetonide in upper lid retraction. With the thorough review of literature, I could only find very well-written 4 case series. And the mechanism proposed is anti-inflammatory effect, because of which the steroid acts very well in these cases, targeting the inflammation, especially in acute phase. But in our case series, we saw even in the chronic phase, it was useful. If we remain ahead of the disease before the chronic fibrosis sets in, obviously it is better and we can get better results. So in conclusion, because of the ease of administration, the short downtime, and the use of this in active phase, it improves the quality of the life of the people, and it definitely broadens our therapeutic arsenal to help these patients. Thank you so much.
Thank you for a very nice presentation, well documented and well worked up. Just a couple of questions. So what was the stability of the upper lid retraction before you intervened? In the sense that we know that a patient who's been recently diagnosed to have thyroid eye disease is still hyperthyroid, starting on anti-thyroid medications or steroids, the lids are going to come down a little bit in most cases.
Yes,
in some it may go up also.
Yes, sir.
So did you look for stability of some kind before?
Not stability as such, because in some of our cases actually it was used even for the cosmetic reasons also, even in the active stage of the disease, because patient wanted, like especially females, they were like 2 mml of scleral show, so they wanted some cosmetic relief also. But it was always started concurrently with the IVMP that was given, and only after the third cycle, the third pulse that we gave, we went ahead with the this upper lid steroid injection, sir.
Right. And was there a toss-up between giving botulinum toxin on which there is a lot of experience?
So we don't generally give botulinum toxin in our practice, because it is very unpredictable, very short term. So that's why we have always leaned towards triamcinolone injection. Yes, sir.
And if recurrence occurs, means retractions
Recurs, ma'am, yeah.
It is there in your study.
Yes, ma'am.
Some patients
Yes,
recurs.
ma'am. They the average like range of our injections was 1 to 4. Some patients, when there was like too much of a scleral show, they even received 4 injections, like
At what intervals?
Ma'am, 2 months intervals.
2 months.
Yes, ma'am.
And if recurrence is there, how will you count whether it is due to the drug loss, means ineffectiveness of the drug, or the activeness of the disease? How, to which you will account?
But mostly the people who are not reacting were those in the inactive phase, because in the active phase, even the steroids was working to help control the disease process that was going on. So active stage people actually responded very well to this steroid injections. The inactive stage people actually required higher dose also, and basically more number of injections, more number of injections.
Inactive stage of the disease.
Yes, ma'am, because the fibrosis are already set in. So inflammation, what steroid is doing is actually tackling the inflammation. So it really works well in the active stage when no other thing can work, like surgery obviously we can't do there. But in active stage also, we saw in 10 of our cases it did respond, but more number of injections were
means
required.
take home message is, in the active stage we can go for triamcinolone injection if
Also.
patient is willing.
Yes, ma'am.
In the active stage only thing we can do is triamcinolone only, na?
In active stage, ma'am.
Yeah.
Yes,
because
ma'am.
in active we have so many options are there.
Yes, ma'am. Yeah.
Botulinum toxin, surgery, anything can there.
Correct, ma'am. Correct.
Right. Thank you very much.
I just want
Sir.
to ask, so like, what do you think that how it works in the inactive stage? Because the steroid reduce the inflammation, and so how it works in the inactive stage?
So, ma'am, like this slide I showed, like one is the inflammatory effect that is shown. Another is aponeurotic detachment. Some studies also say that like it goes and kind of like collects there.
It is a kind of like
Ptosis happening.
medical recession.
Correct, ma'am.
Medical recession,
Yeah.
is that-
And some studies also show that MRI has been done in these patients serially, and there has been a thinning of LPS SR complex that has been
Because this
noted because of the
steroid,
steroid injection. So probably that is the mechanism that is being used, like that is what is happening in the inactive stage, ma'am.
And just one thing that, as you mentioned, then in active, we concurrently give the IBMP also.
Correct, ma'am.
So that can be little, I will say little confounding, because the both goes the
Correct.
systemic
Yes,
steroid,
yes, ma'am. Yeah, we have to kickstart the IVMP, because obviously in that, obviously if it is too much of a lag of thalamus and exposure, we can't do like anything else in the active stage. So this works well concurrently.
Thank you. Thank you. I think we have overshot time, but we have a duty to do. Is Dr. Subhav Prasad